So today we're going to talk about recurrent miscarriage. It's Baby Loss Awareness Week, so it's something of relevance. And so the aim today is to obviously build on our understanding of recurrent miscarriage and recent developments in this field. So there's a lot of new research that's come out in the last few years, so and that coming to practice. So it is of relevance, and it's going to be important to be aware of these changes as we go through managing patients in EPU. So objective today is to, those are our objectives today, so learn about the incidence of recurrent miscarriage, what impact this has on the patient as well as the partner, and what the causes, and how we can support investigators of recurrent miscarriage within the NHS. So a lot of private participants do various things, so we're going to focus on what we do in the NHS and in certain units, and what treatment is available and what new evidence has come to light supporting treatment. So these are the SIPs that it's going to link to. I know a lot of you wanted to know which SIPs it's going to match to, so these are the SIPs it's going to link to in terms of your portfolios. Do link them up, okay? So instance-wise, 1 in 5 women will miscarry in the UK before 14 weeks, okay? And about 1 to 2% of women will miscarry before 24 weeks. You can have a class of late miscarriage. So in the UK, we define recurrent miscarriage as 3 or more consecutive miscarriages in succession. In wider part of Europe, they don't do that. It's very much different. They classify as 2 miscarriages. They do not have to be consecutive, okay? So there can be discrepancies in terms of classification, particularly when you've got a lot of patients from mainland Europe coming, who live here, who know about different treatments are offered abroad. And often it's quite difficult to balance those sort of expectations at times. But we've got to work within our remit and within our guidance, okay? So recurrent miscarriage affects about 1% of women in the UK. There's many causes to it, but overall it can be devastating but traumatic to recurrent losses. And also often you find that women and partners do not find much enjoyment when they do have a successful pregnancy, because that pregnancy is clouded by a lot of anxiety and worries about the fact that not achieving anything that's going to be sort of successful or even a benefit. And what we say and what we do does matter. Okay? And it's important to know that live birth is not protective of recurrent miscarriage. So these are some of the things that people, women, do report, and this is taken on miscarriage social about their feelings when it comes to loss, particularly when it comes to recurrent losses. Okay, a lot of the themes is blaming oneself and not finding why things are wrong. Often looking for a magic tablet that is going to correct everything. Often there isn't a magic tablet. More than 50% of cases are unexplained, and that can be quite hard for couples to actually accept as part of their grief. Okay. Now, this is a video from Tommy. So I'm just going to play this just because it's useful. So So as I said, it can be quite it can be quite difficult things to manage, particularly when you're seeing these women EPUs. So we're going to go through a case and go through these cases together and sort of figure out what sort of questions and sort of answers you would give to a person experiencing recurrent loss. So we've got JD. She's been seen on EPU. She suffered another miscarriage. Her scan today has reported a complete miscarriage. She had been previously seen and had an intrauterine pregnancy of uncertain viability and had bleeding and pain following this. She has no children. She's otherwise fit and well, and no significant medical history of note. And she's been referred to the recurrent miscarriage clinic already by your EPU nurses, but JD has some questions she wants to ask, and you've been asked to see her. Hey, so she asks you, why do I keep miscarrying? Okay. How do you approach this question? This is a safe place, safe environment, because you're going to have these quite difficult conversations, aren't you? So it's important just to explore those things.
I think I've had fewer opportunities to discuss recurrent miscarriage, but when I'm just talking to people who are coming with a miscarriage, I do have like a fairly similar pattern I go through. I think I say, what is it, that 1 in 4 of all pregnancies are going to end in miscarriage. That if it's your first, that there's no implications for future pregnancies. We don't know that yours is going to miscarriage. We so often don't know why, and that frankly, I usually apologize for saying it's one of those shit things that just happens. And yeah, so I'm not sure about how to change that to somebody who just keeps happening too.
Yeah, I mean, it's actually some of the language you use is similar, really. It's important to say, you know, it's not their fault that this has happened, because for them, it's the repetitive loss. It's I'm to blame. There's something wrong with me, and that's what they hold on to. Okay. Also, you know, I think part of this could be like, what do we do next? Okay. What could be the causes, and reflect on the fact that we don't know. Okay. And often you don't know, and that's reality. But it's nothing that she's done that's caused this, okay, or they've done that's caused this, and that's why they will always look at that grief will always stay with them. And then I guess this question leads on to what the next steps are, basically. So for her, it could be. So for her, it could be like, you know, what are the causes? So people will ask about what the causes are for miscarriage. So, you know, people will say, is it because I'm old? And often that's what people, for women, I know age is a big issue, a big factor. And there's always this stigma and expectation of the biological clock and the clock is ticking. When are you going to have children? When are you going to settle down? All these expectations. So it's like, you know, navigating those things and, you know, and emphasizing the fact that, I know, these are difficult situations to be in, but also recognizing, yes, age is a risk factor. So one thing that's proving that, but age is not the only risk factor. There's many other risk factors involved. Okay, there's smoking, there's alcohol, there's caffeine, and also there's not always a reason for behind it. But sometimes when you do find a cause, often and it can be treatable and it can improve outcomes. Okay, that's what they want to sort of look at. There's that hope. There's that thing, but then you have to manage their expectations as well. Because, and like I said, more than 50% of cases you do not find a reason. Okay, same case with regards to stillbirth as well. Loss of the second trimester. Okay, but I guess it's, you know, acknowledging what's happened. It's that acknowledgement of what's happened, but also acknowledging that it's not nothing that they've done that's caused it, but what they're going through, what the next steps are. That's what we're going to go through today. Okay, so you'll know what to do. They may ask you, what is the chance of me losing another baby? Okay, and that's a difficult question to ask and answer, isn't it? Generally speaking, it depends on what the underlying cause is or causing the recurrence. If it's unexplained, the chance of losing another baby is actually quite high. It's like 40% if they've had consecutive miscarriages. And how do you approach that topic? It's like, you know, it can be high. But and then the other question that you go through is like, should I try again? That's the next question after follows. In general, because you're now on this path of, you know, you've been referred to a clinic now. What we're going to do is find reasons why this is happening. So what I advise them to do now, I recommend you don't try again until we know what's causing this, then we can potentially offer treatment and supportive treatment that's going to hopefully support a successful live birth in the future, if that makes sense. So that's what you should recommend trying and waiting. And the waiting is difficult because some of the investigations you do, you have to do them 12 weeks apart and then repeat them again 12 weeks later, before you can formalize a formal diagnosis, particularly when it comes to antiphospholipid syndrome, which is one of the causes, treatable cause for recurrent miscarriages. And again, it's that age comes into it, doesn't it? Like, well, I know I'm getting old and all these other things come down. It's like it's hard to navigate those and support those women during these sort of uncertainties. But generally, you would say our recommendations is like, wait till we know what's happening, because we potentially can improve things and provide a better outcome. If they choose not to wait, then obviously that's their choice. But things you can advise them is like high-dose folic acid and vitamin D pre-conceptually, which will be helpful. And generally we advise of many women who have had any losses as well. The other things that you can discuss with them is like, you could do certain tests already, like particularly some blood tests I will talk about straight after the addiction point. But generally advise is to recommend waiting until we know what's happening.
Do you say wait for one normal period after you've had your miscarriage?
Yeah, so that's why I always say. So I say once you've had a normal period afterwards, people tend to ovulate very quickly after, and they do fall pregnant quite soon after that. But what I would say is once you've had a negative pregnancy test, you start taking the high-dose folic acid and vitamin D preconceptually, and then start trying again if that's what they want. That's particularly with anyone who's had a loss. When you've seen who's come for an ERP, such a miscarriage or medical miscarriage, they'll have this question. They don't always bring that to the forefront, but you ask, do you have any questions about what will happen next? And they often will bring that to you. And I think that RBH, we do a lot of HCG follow-ups, and they always have that question. They don't always bring it to the table, but it's a common question that we want to know about. So moving on to how you're going to answer this question. So when it comes to risk factors, we talked about some of the risk factors. What are the risk factors for recurrent miscarriage? Smoking. BMI, yes. How was that? SA is a cause, so we're talking about risk factors. So things that can modify in a sense.
Untreated.
We can't modify something, so I should correct myself. We can't modify something.
Like untreated coagulopathy.
That's a cause. Yeah. Age, yes. Touched based on some of them, so I gave something away. Risk factors are age, caffeine, that's that biochemical structure, caffeine, BMI, smoking, alcohol, also history. Okay, so previous history. So age, so we know that it's not just maternal age, actually paternal age is important. With paternal age, particularly man's more than 40, the main risk that comes is because of DNA damage, basically, and they're more likely to get non-destruction mutations in the pregnancy, and you get aneuploidy. Advancing maternal age is associated with declining both number and quality of remaining eggs, basically. And this is the statistics in terms of risk of miscarriage. So, with age, risk of once you hit above 40, the risk of miscarriage is almost like it's 1 in 2 chance. It's quite significantly high. But with that comes with the pregnancy comes with the risk of stillbirth, IUGR, SGA, and preeclampsia, and other support maternal obstetric outcomes as well. So age is an important thing, but something that you can't really modify. Which is why it's always difficult to manage those external expectations. Previous miscarriage, so with every consecutive loss, the risk increases, okay? So it's 40% after 3 consecutive losses, and the prognosis of worsening maternal age. Even after 3 miscarriage, most couples will have a live birth, and that's about 60% of women will have a live birth. So with BMI, BMI is interesting. Obviously, BMI has a impact not just with miscarriage, but also getting pregnant. Women may not ovulate, particularly if they've got the metabolic syndrome and insulin resistance. But obesity is associated with both sporadic and recurrent miscarriages. And the sporadic miscarriages are often associated with congenital abnormalities, particularly neural tube defects. You get a 2-fold increased risk in the background risk of neural tube defects, but also congenital abnormalities, so cardiac defects. And if they've got diabetes in the background of that, it's almost a 4-fold increased risk. But the risk generally increases from 1 in 5 to 1 in 4 women, but it's important that low BMI is a risk factor for both fertility, miscarriage, and SGA. So anyone with a BMI of less than 18 is prone to risk miscarriage and fertility issues. So drugs, we talk about smoking, dose-dependent caffeine consumption, and alcohol. Alcohol can be quite difficult to navigate. I mean, I saw a lady who had 3 miscarriages and had was an alcoholic, but you're managing alcoholics in these circumstances, and there's a lot of denial about it, a lot of being quite cagey about opening up about their drinking, but actually if you did an alcohol level that with them, they were quite significantly high. And this woman had lactose 4, but couldn't explain what it was. I said, let's run an alcohol level on her, and it came back at 6,000. So that was why she had lactose 4. So you know, and they're like, why am I miscarriaging? Well, there's an obvious reason why you have miscarriage, because you're drinking a lot. But again, you know, managing those lifestyle changes can be quite difficult. So it's not just something you manage alone. You need to involve, like, you know, difficulties.
Can I have a question that might sound a bit silly in that context? Obviously, when it comes to alcoholism and going way above the recommended amount, obviously there will be a lot of people that are in the middle ground, which are above the recommended, which is it's on the lower side for someone, for example, who's young and what about those?
So you know, this is not causality. This is the risk factor. I'm not saying that this person's going to definitely get miscarriage.
Yes.
Drinking within limits is perfectly normal, and you're okay to drink. But people do drink before they fall pregnant. People have to get pregnant on a night out. I mean, it's a normal thing to happen, but it's not a significant cause for recurrent losses. But the more high, the chronic alcoholics, what we're looking at, basically, those are the ones who are going to get more metabolic issues, if that makes sense, and hence why they're going to get more likely to have poor outcomes. But alcohol use, we already know that you're more likely to get congenital issues with the baby and that sort of aspects of things as well. But I think the other aspect of where alcohol comes to, particularly when it comes to fertility, getting fertility treatment, access to fertility treatment, they often want you not to be drinking alcohol, you need to be teetotal for it. So I think that's where that sort of comes. I think it comes down to, like, because of smoking alcohol, quality of eggs, quality of sperm, and that's where it comes down to. Because you want the success rates, the best success rate. So if you're going to invest in something, for example, like IVF is an investment for, whether it's private or NHS funded, it's an investment for that couple. The success rate is only 30%. Actually, it's quite poor. So in order to achieve the best success, you want to make sure you get good quality, you know, eggs and sperm. So smokers going to reduce that, alcohol's going to reduce that as well. But in terms of miscarriage, that's what they're quoted by. I mean, from my experience, more recently, it's chronic alcoholics. But often they have fertility issues anyway. Getting pregnant is an issue anyway.
And I guess from the point of view of IVF, there's a resource that can be quite difficult to access.
So it's limiting, making, and also it's lifestyle changes, because by reducing smoking, you're going to have better outcomes in terms of your pregnancy, but also reducing alcohol, you're going to have better outcomes for your pregnancy as well. So it's about not just making those interventions now, but also long term going forward. But in terms of whether just, you know, the overall impact of drinking more than 5 minutes a week, whether what that impact has, I don't know.
I guess sorry. The other thing is that if you are a heavy drinker, it's never just a heavy drinker.
No, it's more,
usually
exactly.
a smoker as well. Poor diet, high BMI.
Exactly,
You know,
it's compounding factors, and this is why we're looking at factors rather than causes here. But we are going to go to causes now. Okay, so going to what you were asking earlier, causes of miscarriage, you said one already. SLE, exactly, lupus. What particularly about lupus? What is it that you can get associated with lupus? Exactly, antiphospholipid syndrome. You mentioned
coagulopathies.
What's coagulopathies?
Like hemophilia or.
Hemophilia doesn't actually cause miscarriage. It's inherited thrombophilias. But which thrombophilias?
Protein C and protein S.
Good, yes. What else? Think about things that are going to cause clotting. So to the APLS, protein SC. What are the other ones that we also screen for? Factor V Leiden, that's the one, Factor V Leiden. There's also prothrombin gene mutation. So anything that's going to cause a hypercoagulable state is more likely to cause a recurrent miscarriage rather than a bleeding state. Bleeding state is more likely to cause PPHs, APHs, those sort of aspects. That makes sense.
So bleeding is a problem at the end. Clotting is a problem at the start.
Interpartum also antenatal as well. So certain bleeding, we won't go through bleeding disorders today, but some bleeding disorders, particularly like factor 11, some of those ones can cause miscarriages, second trimester losses. So there can be elements to those sort of bleeding disorders can do that, but we won't touch base on those. You've got your thrombosis, so you've got those, but those other ones that we talk about are karyotypes. So common things that cause miscarriage are some chromosomes.
Is it like balance translocations?
Yes, exactly. Yeah. So do you want to tell us about balance and unbalanced translocations, Christina?
Really fun. essentially is when there's a DNA abnormality from the parent which is balanced, therefore it doesn't affect the phenotype of the parent. However, when it's paired with another set of DNA, then that can sometimes cause aneuploidies more commonly or more frequently than in someone who doesn't have them.
Easy. That's it. But yeah, you did well. And can you finger snaps for saying good?
Oh, so
Finger snaps everyone.
I remember learning that like one of the most common trisomies in recurrent miscarriages is 28.
So when it comes to trisomies, when it comes to like non-destruction, often it's not recurrent. So when often you'll meet a couple who's had say trisomy 22 or trisomy, often it's not recurrent. It doesn't always happen again. And the reason I know this is because I sit in a lot of fetal medicine clinics and it's not really recurrent. What is recurrent is what just means is those unbalanced translocations because the parent has that mutation. And non-destruction often happens because of the meiosis process of gamete production, and that's where it is. Other things are, underactive thyroid, so thyroid peroxidase antibodies can increase the risk of miscarriage, and also diabetes, particularly uncontrolled diabetes, and also uterine anomalies that can be associated with it. And also, particularly second trimester miscarriage, you've got cervical incompetence as well, and infections, bacterial vaginosis. So there's also the unexplained, like we talked about already. Okay. So chromosomal, aneuploidy is the main cause for most spontaneous miscarriages, so often it's non-disjunction related. And that counts for a majority of the first trimester loss, like 30 to 50%, that will be that also for further miscarriages. More common with advancing maternal age, again for gamete production. Parental chromosomes are often normal in these circumstances. So this is why you get non-disjunction. So you basically the gamete production. So you got metaphase 1 and metaphase 2, where you can get extra chromosome, and that's where you get your trisomies basically. The other element where you can get trisomies is basically your unbalanced translocations, but you often get quite a big portion of that DNA that's been has caused unbalanced translocation. And as Despina has correctly said, a balanced translocation in one partner accounts for about 2 to 5% recurrent miscarriages, so quite a small percentage, but it's significant that some would want investigation. Often one partner carries a balanced structural anomaly, and again, parent is phenotypically normal. And the degree of effect of the phenotype depends on the degree of the genetic mutation that is in the DNA that's been transferred in an unbalanced or balanced fashion by autosomal translocation. So again, with unbalanced translocation, some genetic material can be missing or even duplicated. So again, it's not always extra DNA, it can be missing. Pregnancy are at risk of miscarriage or congenital malformation or endo disability. So those are your returners as well. That can be the case there. Risk depends on size of genetic content that's been rearranged. Okay. There's a video on risk for translocations on watch it. Yeah, I'll put it on anyway. Cool. Okay, sorry guys. For those that are online, sorry, we're going to post a link. Sorry guys. For those online, we're going to post a link on chat for you, so you can. I know you can't hear you. Sorry about that. So yeah, as we said, with the number of miscarriages that increases, also unfortunately associated with that, you do lose healthy pregnancies as well, particularly when it comes to eukaryote losses increases, so the income is actually quite normal. So with cervical incontinence, it affects less than 1 in 100 women, but it's the most common cause for second trimester losses. You often will see these women who come in with those early preterm membranes or cervical dilatation. So with the new RCG guidance with 75, so 25 meters or less is a short cervix, okay? So that's how we classify with a short cervix. Not everyone who has a short cervix needs to have treatment, okay? But it all depends on the history. So if they've had a second trimester loss, they will have a cervical length scan with between 12 or 14 weeks, and they'll have a look at the cervical length. And often they will, depending on the length cervix, they will offer progesterone or cervical cerclage. There's now a move to just offering cerclage rather than going for vaginal progesterone now. And that's come from the new guidance. Antiphospholipid syndrome, so otherwise known as Hughes syndrome, uncommon, but it's the most treatable cause for recurrent miscarriage. And actually, if someone has underlying antiphospholipid syndrome, the chance of them having a live birth is about 10%, so quite small. By actually giving them treatment, you improve that to 90%, so it's quite significant. So there's something that's treatable here, which is why we would investigate these causes. So you get antiphospholipid antibodies. So those are the lupus anticoagulants, but you can get anti-cardiolipin antibodies and anti-B2 glycoprotein antibodies. And the reason that it causes miscarriage is because it inhibits trophoblastic function and differentiation, but it also causes an inflammatory response locally and thrombosis at the uteroplacental vasculature, and thus leading to miscarriage, both first and second trimester losses. The diagnosis requires both a laboratory criteria, which is basically having any of those antibodies, and a clinical criteria. So clinical criteria includes an adverse pregnancy outcome or a vascular thrombosis, okay? So 3 or more miscarriages before 10 weeks, or 1 or more morphologically normal fetal loss, which is hard to define, but that's more what we refer to those who have second trimester losses. And one of those who have 1 or more preterm birth before 34 weeks due to placental disease, such as preeclampsia and IUGR. I guess the 1 or more morphological normal fetal loss comes into the stillbirth category as well. Okay, so those who have a stillbirth, we will investigate for APLS as well. And the vascular thrombosis includes those women who have been on the combined oral contraceptive pill within the first year of getting a DBT based on RPE.
Sorry, so is it one of those 4?
Any one of those 4.
Any one of those?
Yeah. Any one of those 4. So that perspective would include any one of those 4, basically. So antiphospholipid is found about 50% of women with recurrent miscarriages, but actually about less than 2% occur in low-risk women who do not have any symptoms or any associated risk, okay? And like we said, with no intervention, women with antiphospholipid syndrome have live birth rate as low as 10%. So anything you do will improve the success rates massively, okay? 30% will have associated immune thrombocytic purpura as well. And there's associated risk of VTE, IUGR, preeclampsia, and also stillbirth. So with thrombophilias, it's often the inherited thrombophilias that you get, and the ones that are indicated are particularly affect second trimester miscarriages and stillbirth, and you get thrombosis at the uteroplacental circulation, and that's where you get the second trimester loss, because at that point you've got the uteroplacental circulation in effect, basically. And the ones that you get commonly associated with are going to be your factor V Leiden mutation, as you mentioned, your protein C and protein S. Protein S is more commonly associated with second trimester losses, and also your prothrombin gene mutations. And what protein S and protein C are very important factors in terms of stopping blood clotting too much. So deficiencies will just lead to blood clotting essentially, which is why people who have protein S or protein C deficiency are more likely to get VTEs and VTEs in pregnancy and all VTEs outside of pregnancies. These women will generally need to be on low molecular weight heparin for the duration of their pregnancy, okay? Depending on whether they've had a venous thromboembolism, they'll probably be on a treatment dose of enoxaparin or intensiparin, whichever one you're using. Factor V Leiden mutations basically they are resistant to being inactivated by protein C, which is why they are more likely to cause venous thromboembolism. So it's more resistant to basically being deactivated, essentially. So those are the main thrombophilias we look for investigations. Other causes, such as congenital uterine malformations, there's not much actual evidence that actually abnormal uterine malformations cause an increased risk of miscarriages, but that's something that we will look for as part of the investigations. And some people will consider treatment, particularly for vaginal septums, septal uteruses. There is a risk of preterm labor, but also risk of birth restriction in these pregnancies if they get pregnant, obviously, and term delivery is about 50%. Endocrine causes, so diabetes. So, those who are diabetic want to aim for HbA1c less than 48. Anything more than 60, you're asking for problems. Those include congenital malformations, risk of miscarriages, but also complicated pregnancies for the duration of pregnancies, but also chance of second trimester losses and stillbirth as well. Thyroid disorders, so anyone with antithyroid antibodies have been associated with recurrent miscarriages, so treatment is always important, so investigate. PCOS, it's thought to be related to insulin resistance and hyperandrogenism. But prevalence of miscarriage in women with diabetes thyroid disease, the prevalence of diabetes thyroid disease in women with recurrent miscarriage is the same as the general population. So you'd always find a newly diagnosed diabetic or newly diagnosed person with hypothyroidism in case of investigation. But we do look for thyroid antibodies and thyroid disease in women with recurrent miscarriages. And that's come from the ESRH guideline. Infection, mainly with second trimester losses. So bacterial vaginosis is associated with second trimester loss and preterm birth. So rubella, toxoplasmosis, and listeria have been associated with second trimester losses, but we don't always screen for them because the prevalence of that is quite small. The role in recurrent miscarriage is unclear. Now, in immune-mediated factors, so natural killer cells have been researched quite a lot, particularly with recurrent miscarriages, and some private clinics are offering steroid treatment and investigations for this. We don't offer this on the NHS, but if people want to have further investigations, this is something that you might consider them exploring, basically. Everyone has natural cells in the body. In the uterus, you do have circulating natural cells. They're more high in prevalence in population during the time of menses. They are meant to be there. It's a normal feature to be there. They actually help with implantation and early placenta development and production of vascular growth factors. It's when you have an increased number of uterine natural killer cells is thought to be associated with a miscarriage because the thoughts that you often are causing rejection of that pregnancy, and hence why there's evidence such as that if you give steroid therapy in women with raised natural killer cells in the uterus, you're more likely to support a pregnancy. But the evidence wasn't significant, and more research is actually ongoing in this area.
You know about hypothyroidism? Sometimes I come across some people who been to fertility clinics and they're just started on thyroid medication, but they don't necessarily have a kind of low thyroid. How do we handle those women throughout pregnancy? We just sort of think about it as a separate issue, or do we have the same frameworks and targets? No,
you think about a separate issue. So the evidence for thyroid disorders and fertility, so the one that TSH should be less than 2.4 to improve fertility outcomes. That's what they felt, particularly ovulation rates. By giving them thyroxine, there was some evidence that will benefit those patients. So in pregnancy, these fertility patients often you got to manage their expectations. So often you would often continue the medication during pregnancy, but often you don't increase the doses. And the target you're just aiming for is less than 2.5, generally speaking. But often you will have a conversation with a particular endocrinologist, have a conversation about stopping it. I think that's completely reasonable, particularly if there's not an underlying cause here.
Yes, you don't refer them to your endocrine. If there's a joint endocrine clinic, you just ignore the fact that they're on the thyroxine, essentially. Because as Jabba says, there's no real evidence. You don't have to check their levels either. They're not hypothyroid.
Thank you.
So she's come back to the Recurrent Miscarriage Clinic. Jade here for her first appointment. She wants to know what the next steps are. So we've gone through some of the causes. Let's talk about what's on the investigation. So what are the next steps would you consider doing? What sort of investigation would you be referring her for?
I think if she's come to you with her third miscarriage, it would be good to if that's going to be managed medically or surgically to think about
Yes, so 75 of cytogenetics, that's very important, yeah. So those are where you're going to be looking for the unbalanced translocations. Anything else you're going to be doing? Blood test, which ones? Come on, I know it's last session. Yeah, TFTs, clotting, yeah.
SLE stuff.
SLE stuff, yeah, yeah. So she,
Would you do a pelvic ultrasound or not?
yeah, you could do a pelvic ultrasound scan.
I don't know if you're going to say, but when would you do the plotting, for
We're gonna
example?
talk
You're going to
about-
come
yeah,
on
we
to
can
it,
talk
great.
about that.
Can I ask a question about cytogenetics? Because I know we are supposed to send those tests when there's a third consecutive. What actually happens to the tissue in the lab? What do they test?
So they look at they do karyotyping and
Do
they
they
look,
do it from the fetus?
they do from the if they do from the placental mass, basically that's what they use usually. They don't take a sample from fetus.
So how do they find the placental mass from a surgical management?
So surgical management, often you can't see the fetus in it. Often
Yeah.
the CRL is probably going to be what, less than 20 millimeters at most, or less than 30 millimeters at most.
Yeah.
Often they put it in the tissue and spread it on several slabs, if that makes sense. I look under microscope to see if there's an underlying, what the underlying histology is also. But they would also take dissections from that and look at centrifuge and also do those karyotypes from those tissues. You can't always differentiate the fetus in the things, so they do this carry as normal. Because when you got a delivered fetus, so this is one thing I will say, this has happened, there's been data about this, it's a massive incident before in the past. If you've got a live fetus, not like a fetus, whether it's a form fetus, do not take, often what we used to do, you get the placenta, we used to dissect some of the placenta tissue and send that off to cytogenetics rather than the whole pregnancy. Do not dissect any tissue from the fetus and send that off, okay, whatever you do, that's happened in the past, okay. So just send the placenta masses. So the placenta itself is quite big, it's often bigger than the pregnancy itself, so you're more likely to be sampling the placenta when you're doing those sort of SMMs, if that makes sense. And often the CRL on those scans are going to be less than 20 meters, so it's often, and they're really apoptosing and degenerating. But the most material you're going to get is from actually the placental tissue, that's formed there, the trophoblastic tissue basically. When it comes to second trimester, so the placenta is often going to be bigger than the fetus. So you just take sample of placenta and send a small sample with a bit of tissue fluid to Oxford basically. And often you don't do it. Someone else is doing it.
Yeah, it's just I didn't know what happened to that tissue after.
Oh, so we don't send the whole. We don't send the whole pregnancy. The whole pregnancy doesn't go straight to cytogenetics. It's just a portion of that tissue they use will go to cytogenetics. The rest of it will either be cremated or buried, depending on what the parents' wishes were. If it was a post-mortem, they would only just look at the placenta tissue. The rest of for cytogenetics, the rest of the baby's tissue will go to what's called PM, and they'll look at all the slides from PM. They'll take tissue samples from baby. That's what they will do as part of the PM, and they will look at the karyotype in the baby at time. Because sometimes when you've got, sometimes you can't always correspond. Some of the tissue, the karyotype in the tissue may not be accurate, same tissue as the placenta. It might not be as, yeah. Just make sure that you've got the same tissue type basically. And you could do further testing as well on skin tissue as well. I think you get more genetic material from it compared to placenta, because often it can be hemorrhagic components in it at a time.
I was going to say, if the lady already has a child, but then goes on to have a recurrent miscarriage, would you still go down the route of?
Yes, definitely, because you got to remember, antibodies don't just are not there at the time of your birth, and they appear over time frames. So does diseases, particularly lupus does at times, and it's an autoimmune process. The autoimmune process can be triggered by many things, and there's different time scales where in age factors where autoimmune conditions are more prevalent, be more likely to develop antibodies, and that's because you can always develop a problem later on. And like I said, your live births are not protective of recurrent miscarriage, so you should offer investigations. So yeah, we move. So cytosine, I don't think I answered your question quite well, sorry. But you send small samples off basically, and they dispose of that. But generally speaking, you often sign the cremation form or burial form over the plans for the disposal at the same time.
My question was, what actually goes to the lab for cytogenetics?
The
and
whole-
what is
so the whole-
what they look at?
So the whole tissue will go.
Okay.
The whole tissue will go, and they would then send it back to So if there's a second trimester or first trimester loss, all the tissue will go, and then they will then look at what the patient's wishes were, whether it was burial cremation, and then they will deal with that way. But if the patient wants it back, then they'll send a small sample of that tissue.
Okay.
Yeah, that's what they will do. So management-wise, so when it comes to management, we'll touch base on that. When it comes to management, there are two published guidelines in place. We got the RCG guideline, which is old, it's from 2011, and then you got the ESRH guideline, which is published in 2017. Now, the definitions of recurrent miscarriage do differ between the guidelines. We say in the UK it's 3 consecutive. In Amsterdam and rest of mainland Europe, they refer us to 2 consecutive, or just 2 basically, which is why they'll offer further investigating treatment sooner rather than later. Investigations-wise, for recurrent trimester losses, you would you do the antiphospholipid screening. Generally speaking, you do it 6 to 10 weeks after the index event, and that's on the ESRH guideline, and then repeat it 12 weeks later. The hematologist will often say, no, do it 12 weeks from the index event, because often the humoral factors can affect the results at times. So it's best to wait, but repeat it 12 weeks later, okay? Karyotype on the product of conception, pelvic ultrasound to exclude uterine abnormalities, and blood including TFTs and TOP antibodies. For second trimesters, you're going to be screening for the thrombophilia. So we don't screen for thrombophilia for the first trimester losses, but more for the second trimester losses, because that's where they're more associated with, because that's where you get the uteroplacental thrombosis, which will lead to second trimester losses. Antiphospholipid syndrome, again, you're going to be investigating for on a pelvic ultrasound scan. Karyotype, as you would do on swabs and blood lymph infection. So the ESRH,
is that the same for third trimester?
So third trimester is much more extensive. So for stillbirth losses, you're going to be doing autoimmune screening for other screening as well. So you're going to be, as well as the autoantibodies for antiphospholipid syndrome, you're going to be doing TPO antibodies, diabetes screening. You're going to look at some of the smooth muscle antibodies potentially.
What, sorry?
Smooth muscle antibodies as well potentially. You might also be doing, you'll be also doing look for lupus as well. So you'll be doing double-strand DNA and antinuclear antibodies as well. So you don't do that as part of your, your recurrent miscarriage screening. You'll also be doing infection screening for metabolic infection screening, quite sort of syphilis, your herpes simplex, your torch screening basically, and you'll be doing more metabolic causes as well. So your diabetes, TFTs, and other sort of causes as well.
Way more expensive.
Way more expensive. And then you've got the post-mortem as well, aspect of it as well. And they may do immunohistochemistry as well on the placental tissue as well. So that's the other things they do, particularly if they're looking for vasculitis in the placental vessels, basically. So in the European Society of Reproductive Health, they focus more on history, which we all should be focusing on anyway. They do antinuclear antibodies and check for sperm DNA damage, but then actually they don't recommend any treatment for it. They just say just do the investigation. That's about it. They do not check for diabetes unless clinical history is indicated. So when it comes to product conception, we've all been there. Sometimes, there can be issues with it. So what potential issues can arise with product conception?
Huh? Can have the right pots.
Yeah, the right pots, yeah. What did you say just now? I didn't hear you.
Sometimes for legal reasons, or I feel like a lot of people are a lot less inclined for products of conception to be tested and handled.
Choice.
Yes.
Yeah.
No, which it is, but
yeah. Anything else? What happens sometimes before you see them. Exactly. Or when you, so say if you're doing a surgically managed miscarriage, someone's put the products of conception in what sort of substance? Formalin, exactly. So once you put your formalin, you can't really do cytogenetics on that. So that can be a problem. So many problems can arise. So JD miscarried at home. What can you do?
She might have
Well, so you're seeing a recurrent miscarriage clinic, so this is
fine.
12 weeks down the line. So yeah, you can. That's it. So you can offer the perinatal karyotype, yeah, because you don't know if she's had an unbalanced translocation. But there's no harm in offering a perinatal karyotype. And actually, I think the new draft guidelines is actually including that in there now, so you can push it off the peritoneal karyotype. And also,
That's probably more valuable anyway, because if
it is.
Well, like if some bit of the placental tissue had some, like you don't really let your
you might exactly. You might not have got a good sample, and even then, you still often karyotype. And often fertility couples with high recurrent, unable to get pregnant, we do often karyotypes anyway. So often you do offer them peritoneal karyotypes. Even though about 2 to 5% of them will have unbalanced translocation or balanced translocation, it's worth offering them that, particularly for that closure. Does that make sense? You're not doing it for any defense purposes, but you're helping to find a reason why this is happening for them. So you offer the peritoneal karyotype. Most common results will be aneuploidy, as we mentioned, due to non-destruction, so they do not reoccur. But if there's an unbalanced translocation, then peritoneal karyotype is needed. And often you just advise that it take at least 6 to 8 weeks to do. Make sure you do the peritoneal karyotype. Do not ask the GP to do it, because it'll never get done, and you just get emails and emails about it. Even though your consultant has said the GP can do it. Okay, don't listen. Make sure you set up the call. This happens in butts a lot. Very much time period. Uterine anomalies. So first time is pelvic ultrasound scan. If there is a uterine anomaly, to confirm the diagnosis, you can do hysteroscopy, particularly the septate uteruses, or saline sonography is quite useful as well. Laparoscopy or a 3D ultrasound scan.
You still do this if they have a successful pregnancy?
I wouldn't, no, because they've got a normal uterus potentially, and you can do pelvic ultrasound scan. And if they've got a normal uterus, then you don't do this. Do further investigation, if that makes sense. So if you first time pelvic ultrasound is normal, then fine. If the ultrasound scan suggests there might be a uterine anomaly, then yes, consider further investigations to confirm the diagnosis. Okay, MRI, role of MRI is undetermined. So then she returns for follow-up again 12 weeks later. These are she's had some investigations back now. She has a normal karyotype. Partner's karyotype is also normal. She has protein S deficiency and anticardiac antibodies. Her TSH is more than 6 and T4 is 4, and she has T2 antibodies. She's got everything going on. What treatment can you offer? This is just to talk about treatments, to get you involved in treatment.
So for the anticardiac antibodies, do you still need to repeat them? You have to have it positive twice?
You can repeat them there and then, and can then stop treatment if you want to. But you should repeat them, yes.
It should be there.
But let's assume she's had the repeat and it's confirmed as well.
Should be like on aspirin.
And low molecular weight heparin?
Yeah, exactly. The aspirin you can start sooner, okay? So start aspirin as soon as they get positive pregnancy test, generally speaking. And the heparin start from 10 weeks, once you confirm an FH, basically. So what about her protein deficiency? You might want to start the heparin sooner. That's the reason I was saying. But I guess it's difficult, isn't it? Because the risk of ectopic and all those things come back. So I think offer an early scan at 6 weeks to confirm viability. That's what I would do, and then you can take start the heparin sooner rather than later. Her TSH is what about her TFTs? What are they telling you? Yeah, she's hypothyroid. So you're going to give her some. Yeah, that's it. You're going to give her some. So start at 50 micrograms. That's what you should start off normally. In an elderly population, start at 25 micrograms because they may get angina if you start too soon. Just be gentle. You go slow with them, but no one's can be elderly and having babies. But yeah, so start at 50 micrograms, and then you're aiming for your TSH to be less than 2.5. That's what you're going to be doing. So treatment-wise, we talked about. So other things to never forget is do not forget lifestyle changes.
Just a quick question. Once they're seen in recurrent miscarriage clinic and then say they've got an explained cause, do you follow them up in the same clinic, or do you? No, you don't. You refer them. So they've got problems.
Yeah.
So then do you refer them to sort of maternal medicine clinic or high risk clinic, basically? Because if she's got antiphospholipid syndrome or she's actually got an actual diagnosis of hypothyroidism, she needs to be seen by an obstetrician in a clinic. And so it's not midfield care, it's consultative care.
And then if it's an unexplained.
If it's unexplained, it's supportive care. So if she's got pregnant, then you don't see them again.
Yeah.
But often, they might refer you to clinic for discussion or counselling, basically. Often they will have other associated concerns, they might have mental health issues, they might require support with. Also, you might offer them aspirin for the duration of pregnancy because there might be high risk of preeclampsia, so sort of things like that.
seen a few patients on psychologist.
Yes. Yes, a psychogest. So there was we'll come to that shortly. In terms of psychogest, if they've had no bleeding, there's no evidence to give psychogest. That's often something that's come from the PROMISE trial. So the PROMISE trial was looking at luteal support with a psychogest, basically. So that comes from the fertility clinic a lot. There's actually not enough strong evidence to give it. In RBH, we do give it, and some other units do give it as well. Because there is some benefit in high order miscarriages. So people who have four or more miscarriages, they will often there is some benefit in that subgroup of women. So yes, we would offer it to them, and it's something that they would want, particularly in the unexplained. But generally speaking, it's a no. But some units do it. It's not in the ASRH, and also the RCG do not recommend it.
So it's like,
They don't. They recommend psychogest if you have bleeding in pregnancy.
And any previous miscarriage.
And any previous miscarriage, which we'll come to. That's in the PRISM trial. We're talking about this recurrent miscarriage. In this setting, she's not pregnant yet. Okay.
Yes.
So some people. So the PROMISE trial was, as soon as you got a positive pregnancy test and you had a recurrent miscarriage, they gave them psychogest BD 400 milligrams. Okay. There was no evidence to improved outcomes in just of pregnancy. But in women who had 4 or more miscarriages, there was some benefit. So which is why some units, guidance is guidance. You don't have to always follow it. So some units have their own guidance. So our unit do offer it, particularly if you've got some fertility experts there, they will offer it under their guidance. And advise them it's unlicensed, first of all, but it may offer some benefit, but in some subgroup women.
and is it only if they're bleeding, or can you give it?
So the PRISM trial,
Yeah.
that's if they're bleeding
Yeah.
and if they have had a previous miscarriage, right? We'll come to that.
Sorry.
But just to get to your point, if they've had previous miscarriage and bleeding, offer them progesterone, provided they're less than 12 weeks, okay? And they have an intrauterine pregnancy.
Yeah.
That intrauterine pregnancy can be of uncertain viability or viability, okay? Because remember, if you've got uncertain viability, what are you going to do? You're going to rescan them, aren't you? But give them the progesterone. Do not withhold that progesterone just to wait for a heartbeat. Yeah. Give them the progesterone, rescan them 7 to 10 days later, depending on whether you did a TA scan first or TV scan. If you did a TA scan, 2 weeks, TV scan a week, okay? And rescan them to see if there's a heartbeat. If there's not a heartbeat, the diagnosis is what? A miscarriage, exactly. Then you can say, we're not going to continue the progesterone therapy. But most of these women who have recurrent miscarriage, if they come with bleeding, what are you going to do? Give them progesterone. Right? Because the PRISM trial is not supporting that significantly. Okay, and we'll touch base on that. Okay. So remember, do not forget lifestyle change. When it comes to anything gynecology, when it comes to your part 2, part 3, first dimension, lifestyle changes, okay? Smoking, your alcohol, your caffeine, weight loss, okay? If the diabetic, optimize the diabetes. If the clinical hypothyroid, treat it. Now, in our local guideline, if they have subclinical hypothyroidism, we would offer them thyroxine, okay, to aim for TH less than 2.5, even if they don't have TPO antibodies. If they have TPO antibodies and the TSH is less than 2.5, we don't treat them, okay? If the TSH is more than 4, we give them treatment, okay? That's what we do.
Sorry, that was even if they have TPO antibodies.
Yeah, if they're less than 2.5, we don't treat them. If they have subclinical hypothyroidism with TPO antibodies, then obviously you can treat them, okay? Because they're going to get hypothyroid at some point, okay? But the general aim is less than 2.5. TSH is less than 2.5 is what you're aiming for. Weight loss, stop smoking alcohol. APLS, as we talk about aspirin and lomocriptine, it improves pregnancy by about 90%, so it's significant, okay? So it will definitely improve outcomes. And it decreases miscarriage by 56%. But remember, regardless of what treatment you're giving them, they're still at higher risk of, in all trimesters, of getting a small baby or a growth restricted baby, having a second trimester loss, and also preeclampsia, preterm labor, VTE, and also stillbirth, okay? So their risk does not just go away, which is why they'll be referred to maternal medicine clinic or high-risk clinic for further follow-up and support. Inherited thrombophilia, so you're going to start them from, if there's second trimester losses, you're going to start them from 10 weeks. Increased birth rate by 89%, live birth rates is quite good, but if they've already got a VTE in the background history, for example, if they've had a previous DVT or PE, you're going to start it sooner rather than later, okay? And often there might be a long-term, anticoagulation anyway. Surviving competence, so you're going to do a transvaginal scan. That's the most reliable method, so do that 14 weeks. If it's short, 25 minutes or less, then consider cerclage. There's no evidence of prophylactic cerclage, okay? So it has to be when it's less than 25 minutes or less. So there's different types of cerclages. So McDonald's cerclages and Schroeder sutures that we do. Abdominal cerclage is something that's often done in JR. I don't know who does it now because the time price is gone, but managed done laparoscopically works really well. They always need cesarean section for mother birth, okay? You would consider those if, for example, if they've had a failed cerclage and they had a loss, or then you would refer them on for abdominal cerclage, and that's before they get pregnant, okay? So uterine anomalies, again, insufficient evidence regarding surgery, but generally speaking, if you're going to offer them surgery, do a transcervical route, don't do a transabdominal route because you're going to increase risk of abdominal gastric placenta and rupture, particularly. So again, it's not something you would always do, but counsel them appropriately. Abnormal parental character, just refer them to geneticist, okay? Options include prenatal diagnosis, so you need IVF for that, gamete donation or adoption. If they're opting for prenatal diagnosis, then there's advice in that the IVF is costly, obviously, and the live birth rate is only 30%. They're more likely to get pregnant more naturally with a 70% success rate. In terms of them getting a baby that's unwell, the risk is small, actually. They like to have a healthy baby, but 80% of them will have a healthy baby without any problems. Okay? But again, they need that genetic cancer because it all depends on the degree of genetic material that is involved in the advanced translocation, as Justina had rightly said earlier. So other treatments, there's no evidence for giving HCG, metformin. Those things are all for ovulation, okay? So it's important to make that quite clear in terms of distincting them. We're not doing a fertility supportive treatment here. We're trying to minimize the risk of miscarriage, okay? Immunotherapy, so they looked at immunotherapy and actually causes more harm than good. So they looked at these people who can recurrent miscarriage with natural killer cells antibodies, but generally speaking, do not offer immunotherapy, immunoglobulins. Routine progesterone, the answer is no, but many do offer, as we talked about, particularly the PROMISE trial. So again, it suggests some benefit in high order recurrent miscarriage, more than 4 or more, basically, okay? And you're giving that as soon as they get pregnant. Positive pregnancy test, start the cyclogest and continue. Under the NHS guidance, we don't do it, okay? This is your local trusts may do that, and experts in your trust. If there's bleeding, please give them progesterone and get them the scan booked. And if it's pregnancy in the right place, continue it for 16 weeks. Again, we scan them if it's IUP of unsuch viability, basically. Steroids, some evidence, but in those with raised uterine natural killer cells, again, more evidence, more research needs to be done in this area, but there is some evidence for it. And if they want to be investigated for this, they need to be referred to a private fertility centre. We're nearly there, sorry.
Sorry, if you go 2 slides back.
Oh, yeah, sorry, yeah.
With the IVF, do you mean like with donor sperm or donor eggs, or what do you
No,
mean?
so
Because they
they're
can conceive, can't
they can conceive. So using
Yeah.
basically what you do prenatal diagnosis, you want their eggs, their sperm,
Yeah.
and you're checking the baby's sort of embryo's DNA, but that's
to
its
make sure
DNA,
that it's
to make sure it's okay.
right,
So that's prenatal diagnosis, basically. If it comes to gamete donation, then obviously they're going to need. It depends on where the problem lies.
Yeah.
If it's if it's the father, then you don't really need you can just do intrauterine insemination.
Yeah.
It's perfectly fine. If it's the mother, then it's going to be if gamete donation, then you need IVF. Okay. So what about those who have recurrent miscarriage? So supportive care, so you don't give any aspirin, don't give any low-molecular heparin. But large fertility clinics will do that. Okay, they'll even give them steroids, but there's no evidence for it. Okay, supportive care, so they offer them early scans. So they offer them a scan at 6, 8, and 10 weeks just to see how things are going. Some units offer progesterones. Again, it's from the PROMISE trial. That's something that we do in RVH, and something that they do. I think they do that. Do they hear their website at all? Does Dr. Yeah, I think Ms. Hussein does it a lot here. Yeah. Anyway, no, I won't talk about that. But anyways, yeah. So a lot of people do what you can do. It's not going to cause any harm. What it's going to do is cause a lot of discharge, okay, which is not always nice. If it's causing a lot of vaginal discharge, they can always, and it causes a lot of irritation, you can just put it in the bum, okay. That's another way. That's another route to do, and it works similarly, okay. 77% will get live birth rate. Now, there is evidence to give vitamin D supplementations and high dose folic acid, so give them preconceptually, and that's from the ASRH guideline, okay? So do offer them that. 1,000 units vitamin D is what you offer them.
But the 70 to 75% live birth rate, what is that? The unexplained.
Unexplained, yeah, you just
with just this.
with just nothing really.
Nothing.
Yeah.
So you can reassure them with that.
Reassure them with that. But it's hard to accept nothing. Does that make sense? So supportive care is what you give them, which is basically those early scans, the reassurance, and like, is there anything off-label use that you might suggest offer them? Which is why those progesterone comes into it, where aspirin might come into it as well. Okay.
Presumably that number isn't the next pregnancy. That number is like if you just keep going at some point.
Yeah.
So what I'd like to know, Jabba, is that how should we manage these women antenatally once they've got past the first trimester?
Once they've got past the first trimester, I think in these women, particularly if they're on progesterone, you stop the progesterone at 12 weeks. Okay, there's no evidence to continue it. I think often they have other risk factors, particularly for preeclampsia, and I often do offer them aspirin, and aspirin might be beneficial in reducing the risk of preeclampsia and ST1 in those circumstances. You don't offer them extra scans. There's no evidence to offer them extra scans. Okay, it's a lot of it is just reassurance, unless you can tell me something different.
No, I'm not, because I triage all the antenatal referrers in Reading, and there are a small proportion of women like this. They've had 3 recurrent miscarriages, and we still offer them an appointment. And I don't know what happens in other units, but we don't actually do anything for them other than saying, "Oh, you've got past 20 weeks, well done."
Yeah.
Because we don't do extra
No, we
scans,
don't.
because that doesn't provide any reassurance. And as much as you might think it's nice to offer someone a scan, actually it can cause a lot of anxiety for them, because actually, is this going to be okay? Is it not? Does anybody know what care is offered in other units antenatally? I always
I
wonder.
haven't seen them for that in antenatal clinics. So
They're not.
I haven't seen them.
You
here,
haven't,
but
yeah.
No, it's still, yeah, I haven't
Yeah.
seen it.
I haven't seen that.
Well, I've often thought, what is the point of seeing these women? But yeah, we do in Reading, but we do lots of unusual things in Reading. Okay, yeah.
Are the scans more for reassurance though for them? Because if they're not worried,
The early,
they didn't.
the early scans are for reassurances, but not for obstetric antenatal. Once they're on the obstetric pathway, they'll get a 20-week scan, and that's it. But if you're in JR, you'll get a uterine arch Doppler, and that will put you in a path where you get 36-week scan or additional. Well, you get 36 scan anyway, but whether you get additional scan at 20 weeks, 32 weeks.
You said you stopped the progesterone at 12 weeks,
Oh,
not 16. 16.
So this is from the promise trial. Remember, this person has no bleeding.
Oh,
okay?
I see.
If they have bleeding, stop at 16 weeks. Okay. If this is those women who have no bleeding, you just found out they're pregnant, they have history of recurrent miscarriage, you give them cyclogest till 12 weeks. And the reason you give it till 12 weeks is because that's the criteria they use in the promise trial. Okay, that's what it's based on. Okay. Whereas like the bleeding is till 16 weeks because that's the criteria they use in that study. Okay, because we know that's where evidence comes from.
I find it really hard sometimes to say to these women that they don't need to take it for any longer, because they're like obsessed with
They're obsessed with it, yeah.
Like this is
they
what is
are.
keeping this pregnancy going.
And a lot of
They
people
love it.
often continue to 30. Some people will continue to 32.
I've seen people, yeah, I've seen people taking it into like 32.
Yeah.
But please prescribe me some
Because
more.
because people with preterm birth, the ones that we give cyclogest to, they often continue to 34 weeks or 32 weeks, which is why they continue that. But they're not actually at increased risk of preterm birth, provided it's not a second trimester loss. Does that make sense? If it was a second trimester loss, you automatically going to get a transvaginal scan. You automatically get a God progesterone anyway, potentially. Okay, and you're going to have serial scans, transvaginal cycle scans, and you may more likely to get a cyclage once that cervix starts shortening. Okay, so those are the patients that are going to be more at risk, which are going to benefit more from progesterone. Okay, so but for the guideline and for this topic, we're just including them all because we're going to investigate them somewhat similarly. So there you go. She's now 10 years. She's pregnant, and she's 10 weeks, and she has she's on aspirin and she's on noxaparin. She's on it, and her bleeding has stopped. She asks you whether she should continue aspirin and noxaparin. What do you say?
Yes.
Yes. Thank you. Is there anything else she can take? Exactly. Now we go into vaginal progesterone. We got there, okay. So just to say, with vaginal progesterones, when you have any bleeding in pregnancy, like about 20% of women will experience bleeding before 12 weeks, okay, in pregnancy. When you have bleeding in pregnancy, those threatened miscarriages, okay, that we class them as, the risk of miscarriage increases to 1 in 3, okay? So the risk of miscarriage does go up. So you can say to them, the pregnancy is 1 in 4, but actually it has gone up by a certain percentage, okay? But we'll, you know, this is what we're going to do. We're going to do a scan, and if the scan's in the right place, we can offer you progesterone, okay? 2 in 3 women will go on to have a term birth. So that's the other thing you can reassure those women about, okay, who have bleeding in pregnancy. So the PRISM trial, you all know about, okay? And now it was published in 2019 in the New England Journal of Medicine. It was a randomized double-blind placebo-controlled trial, and it was done in the UK. So that was so what they used was basically cyclosporine twice a day in the vagina till 16 weeks, and other half of the group after placebo. And what they found was that those who have no previous miscarriage, there is no benefit actually. But there is benefit after 1 previous miscarriage, okay? More so the more miscarriages you have had, okay? So those are the study findings. This was subgroup analysis, okay, in that study. So as you can see, that there's more benefit with 3 or more previous miscarriages. And it doesn't have to be consecutive, it can just be any order, okay, so you're aware. So this has now been adopted by the NICE new recommendations in November 2021. So those are the guidelines, okay, as we've already mentioned. So you're going to use the 100 mg twice a day in pregnant women with people for less than 12 weeks gestation, okay? If they're above 12 weeks, I give it to them, okay? There's no harm, the baby's okay. I would offer them to, if they have a recurrent bleeding in the 2nd trimester, it might be worth offering them a cervical lens scan, and obviously look at the cervix, make sure there's not obvious abnormality in the cervix, okay? Because that's the thing you want to worry about, and check the smear history. I had to get approval from my boss here once to give that, but never mind.
What was that?
It was 12 weeks later.
Okay, okay.
But always ask your seniors to get agreement, okay?
Is the progesterone dose always 400 milligrams?
Always 400. Always want to be D in miscarriage criteria. In preterm birth, it's once a day.
Once a day,
Yeah.
Yeah.
So it's once a day in preterm birth, okay?
Later preterm birth when it goes until 30 weeks.
Yeah, it's once a day.
Both the PRISM and PROMISE settings of both
BD, yeah, BD. Because luteal support is most important in those early stages because it's trophoblastic implantation and growth, and you want to support that. And we think, but like once a day, you would think actually you're more at risk of losing a pregnancy with preterm birth later. Why would you once a day? You want to give more. But actually, it's just once a day. That's what the evidence is. But actually, when it comes to preterm birth now, you if they've had 3 consecutive history of preterm birth, 3 or more, you don't even do a cervical lens scan. You just do a cerclage. They go for cerclage now. Okay. Before we do cervical lens scan, we just send them for cerclage. That's what they do. Okay. If they've had 1 or more less than 32 weeks, then we do cervical lens scans. Okay. And then you may offer progesterones, you may offer them a cerclage. Okay. But there's new guidelines that just come out. Okay. But have a read. Okay. It's quite interesting. Like many of the great guidelines that come out, it's very grey. It's not as good. Like with the steroid guideline, what do you do? Like give or not give? Nothing's quite clear these days anymore. But yeah, have a read of the new guidelines, quite good. But anyway, going back to miscarriage, second trimester, this is what we would do. Okay, this is supported, so you should be doing that. You don't have to check with your colleague. Just ask the woman has she lost before, offer it. Okay. But just remember the potential increased risk of miscarriage rates. Okay, so we're going to see more and more miscarriage rates now because of that. What we're doing.
Yeah.
So in summary, so recurrent miscarriage is uncommon, but it can have significant couples. Investigations look for treatable causes. However, for 50% cases, no causes found. But if there is, the treatment is available for underlying cause, and it can significantly improve outcomes. And there's now new study findings that do offer some hope for women with history of miscarriage. Okay, and that's the references, and that's it. Any questions? Thank you, everyone. Sorry, I know last presentation of the day. That's it. All right, thanks, guys.